Okay, we are at chapter 14, Fundamentals, and we're going to explore more adaptive massage concepts related to populations. And we are going to begin with, share screen, oncology care. So as I had mentioned at the end of the previous video, there is a learning curve in this area related to safe and beneficial practice that would probably require some additional education over and above what's in the textbook here in order for you to feel confident with working with this population that can be quite fragile in terms of the treatment, the psychosocial aspect of the diagnosis and how people respond. Though cancer care and treatment has progressed extensively, and many of these conditions either are reversible or treatable or managed as a chronic condition, there's still a real fear with the diagnosis of cancer. So those are things that need to be explored. Depending on the treatment process with an individual, especially related to radiation, you may need to be very careful about what kind of a lotion or lubricant that you use. Adaptive capacity is diminished. The treatments take a lot to respond to. And so they're very fatiguing. Appetite might be affected. And there's a lot of complexity here. Way bigger than the diagnosis of cancer and the treatment. So there are people that are offering really good education in this arena. Tracy Walton is one, and Heal Well with Cal Cates is another. And so, and there is an organization specifically related, it's the Society for Oncology and Massage, specifically related to both a certification process, a real one, and a little bit of vetting of some of the quality related to the continuing education in this arena. So in this section, we are going to describe an overview of this. And if you are cautious and gentle, you should be fine in working with somebody, especially if you know the individual. And so, but to really reach out and turn this into a specialization, I really encourage ongoing education in this. I myself have had a lot of education in this arena, have worked with people from diagnosis all the way through remission and ongoing treatment, post-treatment conditions that can occur, like with neuropathy and some cognitive changes related to the treatments, and on through their dying process. So any disease process, including cancer, that is going to progress, there's going to be an acknowledged progression to a dying process, including working with people in hospice. This requires internal soul searching on this, because once you start with somebody they need a level of continuity in their life. And so, it's takes a lot to work in this environment. And most of it has nothing to do with massage and everything to do with a person-to-person relationship in a therapeutic alliance. Certainly, if there's active care going on, active treatment, there's going to be a multidisciplinary situation. And cancer treatment centers were one of the first medical environments to reach out and be inclusive with massage therapy. And there's been a lot of research related to the value of massage therapy in comfort care. And so this is a good place to be able to specialize if you're looking for research-based justification, because it does exist. So then here are the various treatments. That's what you've got to understand. Or what are the other treatments that somebody is going through? And so surgery is common. And so you're going to deal with that massage-wise as it's an acute injury, surgical. But you also have to remember that along with other types of treatment, there might be a slow progression in the healing. So things that might take a week might take 3 or 4 weeks because of the other treatments. So the focus here is to remove as much of the aberrant cells that are not behaving. They are moving around, and that's metastasis, and or crowding out or replacing functional tissue. And sooner or later, if it goes unchecked, then there's going to be interference with the ability to maintain homeostasis. And then, a deterioration will progress. So surgery, it helps get rid of a lot of those cells. And then the other treatments like radiation and chemotherapy don't have quite as big a job to deal with. And sometimes if the location of the cancerous growth can be totally removed, then it doesn't progress any further. So you see that a lot with in adolescents, where they'll get, I think it's osteocarcomas. It's in the bone, and they will oftentimes have to have the limb amputated. And then there's ongoing care with helping that person manage the compensation, adaptation to a prosthetic, etc. Chemotherapy also targets, both of these target fast-growing cells to kill them. And so this is almost like a controlled poisoning. And so it takes a lot to be able to withstand that. And the support and the strength and the resilience that somebody has to go through this is very important to the emotional state and the quality of life somebody might have, regardless if this is successful or that it was unable to be checked and the person is going to die. So these are some of the side effects that can be very miserable related to chemotherapy, and they're making great strides so that these can either be managed or the dosing can be altered. And one of the lingering effects of chemotherapy and radiation can be nerve damage, neuropathy. that even if the cancer process is controlled, there can be secondary problems, and neuropathy is very hard to control. And massage is not necessarily very good at helping that either, because we're stimulating nerve endings that are already not functioning very well. So this is where we are also very active when we see the gift of palliative care. And we used to think of palliative care in this sense as end-of-life care, and that's not necessarily the case anymore. There's been a distinction here where palliative care is about managing pain and or dysfunction, and being able to still have a level of quality of life. So the treatment is not necessarily curative in a palliative care approach in this type of a circumstance. But the intent is to manage and increase quality of life as opposed to being curative. So when we're thinking of massage in a palliative sense, regardless of the population we're working with, we're thinking about comfort care. So somebody does not have to be sick, or somebody doesn't have to be in excruciating pain, or somebody doesn't have to be at the end of their life here for a palliative approach to be very beneficial. Somebody who's very tired, has had a tough week, has been tasked to multitask. You know, there are a lot of places where the general massage that has a comforting approach, that doesn't mean light, that means pleasurable. So the palliative idea is much bigger than just end-of-life care. So here are some cautions to consider. And there is an expectation that the individual will be working with an entire care team. Being able to communicate with them is important. Active care and treatment would be certainly within the medical environment, although various cancer treatment centers have been progressive in reaching out for a more holistic approach, a body, mind, spirit approach, taking from a hospice approach, but not as a process for supporting the dying, but as a process to support the living. Okay, so this is one where I suggest if you're going to really work in this regard, you have additional learning, and you can learn a lot, but on your own through a literature research, looking at PubMed on the cancer-related research and massage, exploring the American Cancer Society. There are a lot of resources for you to learn on your own, but in this instance, I think it's very helpful to have some support from an individual or a group of teachers that have specific experience in this area. So this then is going to talk a little bit more about working in an environment. Takes off a little bit from where we were describing how we might be in a situation as we're caring for people that have had a cancer diagnosis, regardless of where they are in their process, whether they've just been diagnosed, whether they have had they're in active treatment, they're in remission. You know, this situation here, these environments, hospital, long-term care, and hospice, there's some of the same components with this. And these are what we would consider from chapter 13, medical environments. And so what do we particularly do that would be a little different in these kinds of situations? So hospital these days is acute care. Long-term care, whether it's a senior long-term care or that's it can even be progressive from assisted living on through really focused care and or hospice environments, either in home or in facilities focusing on hospice, to be able to function in these environments and adapt. And I'm going to tell you again, it's primarily a palliative approach with a relaxation stress management outcome. In long-term care, maybe there would be a little bit of condition management, and sometimes it is a rehabilitation process. So like if somebody had broken a hip or something. And you can also, in long-term care, don't think of this as the elderly. This may be people who have are managing other conditions that require that they have ongoing people that watch their health status and help them with activities of daily living. So the hospital situation is new. These are the areas that would be targeted in this acute care situation. I don't know what the future is for massage therapy in an acute care situation. The COVID-19 pandemic really brought forward the idea of essential/acute, and the medical personnel and the first responders that work in that arena, as opposed to what's called second responders or third responders that are working further down the line when it's not a life or death situation anymore. And because of the way the finances are within hospitals, they rarely are dealing with something that is in a long-term care or a chronic situation. People are in and out. And if they do need extended care, it's not in the hospital, they're moved to a rehab facility or something. So this is where palliative care shines. It's where it lives. And we want to make sure that we're very respectful of that. And then we also, I refer you back to chapter 13, the medical setting, so that you can appreciate how you as an individual massage therapist would adapt to the setting and the supervision and the hierarchy of care and the charting and the infection control and everything that goes with it. So here's this mentoring tip. Earlier I have, or through this series of videos, I've mentioned that I had open heart surgery, and it was in 2007. It really opened my eyes, experience-wise, to the importance of attending to your general health, the importance of a regular physical lifestyle, and then also dealing with the real eye-opening, life-changing event of dealing with your own mortality. And so I had mentioned also how Luke, and there he is when he was much younger, but practicing massage, attended to me, and he did this in the hospital. This is like a day after the surgery, and you can see the kind of the comfort on my face related to him massaging my scalp. And here you can see the scar and all the tubes and all of that. And then here is an adaptation to working on the upper back that, through the position I was in with the surgery and some other things, was at that time more painful than the actual incision area. So this was actually in the hospital at the time, and so we lived this and had the experience of not only me facing my own mortality and with a serious surgery like that, and then the healing that goes with it. And I had some cognitive problems afterwards. I still have a little of that. I have a little linear thinking issue, and I have a little aphasia. You'll notice that if you really look for it when I'm talking. So hard experience, wouldn't wish it on anybody, but for our family, it was also a valuable experience. So pragmatically, there's the idea of adapting to the hospital room, knowing how to work the beds, the equipment, working around IVs and all of that. The medical devices that are in play, all the tubes, the leads to the equipment that they're using to monitor what's going on. So that is where a lot of the learning curve comes in there. And then one of the things they were so careful with me is infection control. Both systemic infection, they were very concerned about pneumonia, and they swabbed my nose on a regular basis. And I was in the hospital 5 days. That's long. It's a long time. I think now they've even cut it back to 3 days. The sanitation was stepped up because the secondary infection, I mean, it hurt to breathe. I can't imagine what it would have felt like to cough. So that also becomes a consideration in this environment. And I really think in the hospital setting, personal opinion here, I think somebody that has nursing background at the least level of training as a certified nurse assistant, then an LPN possibly, licensed practical nurse, that cross trains with massage. I think they probably are best suited to work in this acute care environment. Now, long-term care, now that's another place where you see a lot of certified nursing assistants and LPNs and BSNs, bachelor's degree nurses. But most of the one-on-one care in long-term care is with sometimes it's called a patient aid technician, a certified nursing assistant, certified nursing technician, patient care technician. These are all terms that show up in this. I've mentioned before, this is a cross-train, and it is a vocational level diploma type process, and then there's not typically licensing, but there is a external certification process that can be taken that validates that you've gone through the appropriate education and have the skill set. And then end of life care and hospice care. There is an expectation here that death will be the end result. And the focus is to make that as positive and as comfortable an experience as it can be. It takes a real dedication to work in this environment. You have to be aware that the people you're caring for are going to pass. And can you do that? Can you care about them? Can you be compassionate? Can you be nurturing? Can you open your own heart to them, knowing that they're going to leave? Not everybody can do that, but those that can, those that have a vocation for that. I have heard people say, I've heard the term midwives to the dying in relationship to hospice. We don't die very well in the Western societies, and we're all going to die. And there's no way out of that. There is some specialized volunteer training that you can take to be a hospice volunteer that could be very additive in this, and if you wanted to provide massage in this environment. And the hospice environments are hiring massage therapists, and so they see the value of the comfort care in this important time of a person's life, as well as the family. So you would be likely involved in that whole situation, whether you worked in a residential hospice, a hospice floor in a bigger medical setting, or in-home care so that the individual can die at home. And you have to also think bigger than the dying person. You've got their entire family support system, et cetera, around them. Okay, here's a little box that talks about providing massage in the home. There's lots of reasons why you would provide massage in the home. I mean, I've done a lot of this with athletes that really can't go out into public without being on stage. And so I've gone into their homes. And this is a very viable practice setting, is mobile. We talked about that in the business world, or in the business chapter. So, but there are some accommodations, some things that you can do to help you move in and out of that environment, not just in hospice care, but across the board. And here are some suggestions for that. So there are additional resources. There's Elizabeth Kubler-Ross and Bernie Siegel. These books were written quite a few years ago, but they're still valid, that you might want to continue to your own learning on this. And then here again is some suggestions around ways that you would adapt to this type of situation. This table gives the general idea of the stages of death, but you know what? It's people don't follow the table that's here, so you can't make any generalizations. This is kind of how the physiological functions begin to shut down, and it can give you an idea, but nobody can nobody can determine when that is going to occur. So, as we move on this, now we are going to have an overview of individuals with a physical impairment. So this would be that they have had a car accident where they have crushed an ankle and they have to have a brace on it long term. Or somebody that has a visual issue and or hearing. So there's a whole list of things here and how we would adapt to that environment. And I'm going to tell you again, there's no massage protocol for this. This is about people, and including you in a therapeutic relationship here. And people get uncomfortable in situations where they don't know what to do. And the first time you have worked with somebody that uses a prosthesis or uses a wheelchair, or it has a muscle atrophy condition, or cerebral palsy, and maybe not be able to control motor function as well. Somebody might have a physical disfigurement, and you've never been there, then you don't know what to do. And you stop and we all do this, go, oh, what if this were me? How would this affect my life? What would go along with me? And you've got to know that we all do that. And then you got to go, but this isn't me. This is their world. And I need to know how to function effectively in it. And once you get past that and you are able to ask questions to help you do that, then you can get beyond seeing the disability, the dysfunction there. You can get beyond that and start to look for function, quality of life, how this person is adapted, all of that. Most of the time, people are not ill. You know, they're perfectly healthy, although if there are mobility issues, they might have, maybe it's more difficult for lower limb circulation or something. But these people are not sick, and we have to, go, and these people do not have a developmental disability. So you got to not treat individuals like they are children and be, that's demeaning when you do that. But you do need to have a facility that supports their ability to have quality function within it. So barrier-free access and your local zoning commission, your local building code departments, they can help you with that. And you want to make sure that if you are going to rent a facility or buy an actual facility, that it is barrier-free. Both access in and out, doors are wide enough, bathrooms are designed for mobility of a chair, and all of that, okay? Then these are some general suggestions for working with clients that have low vision, have a speech impairment where it might be hard to understand them. they have some hearing loss. And again, here's your mobility impairment. And there's a difference between an impairment and a disability. An impairment, we talked about this in People First Communication. An impairment is going to require some sort of responsiveness. So having a barrier-free environment, for example. An individual might use braces, canes, wheelchairs. They might be mechanical chairs or electronic chairs, or individuals may have hearing aids, and how you might need to pay attention that you don't cup over the hearing aids because they will squeal. How are you going to understand an individual who is not speaking in a way that you are familiar with? And this also can include English, a second language, or somebody that does not speak the language you speak. I live with the low vision and the visual issues, and it's been particularly a factor in the last 4 years with the glaucoma. And then I mentioned I think in the animal area that Luke's significant other works with leader dog. So that is supportive and adaptive for low vision. And so, one of the things, if there's a service dog, regardless, don't interact with the dog when the dog is working. It's a stressful job. Just the dog is helping the person, and we need to be interacting with the person. Now, that does not mean that there is not going to be a little bit of a relationship that will occur with a service animal. If you see the same person over and over again, they'll become familiar with the environment and with you, and there'll probably be a greeting. And I've got leader dogs around me all the time these days. And so, but we have to remember that these service animals have a job, and we don't want to interfere with the job and make their job harder. So just leave them alone and ask for guidance from your client. Sometimes a client will need some assistance and sometimes they won't. They need to teach you what that is, and you need to be open to learn, and you need to ask. There are no hard, fast rules here. So the adaptation is that you are comfortable with seeking information and following instructions. So it's about you getting comfortable. Now, brain injuries, traumatic brain injury, even some level of dementia or altered cognitive function, these are invisible lots of times. You don't know that they have occurred. And concussion could be a reason. There could have been a stroke, whatever has happened here. And people are not always forthcoming. So being focused on getting the right information during your history taking is important. And the more confident you are in asking questions, especially when it's not observable, like lots of times with a stroke, there will be some paralysis involved with that, but not so with a concussion. that has caused persistent or ongoing or changes in cognitive or motor function or sensory function or whatever else can go on with a central nervous system injury. We need to say, have you had a brain injury? And what do I need to know about that as your massage therapist to be able to respond and adapt to that? The client is the one that's living with this. They should be able to give you that information. And it may be that you would ask permission to contact and confer with a support person. You'd have to have a release of information if you did that. And certainly you're going to want to investigate and learn more about it and what medications people are taking to help with that. But don't think that there's one size fits all on this. There's a tremendous amount of variation here, and it can affect personality. It can affect decision making. It can affect abilities to cope, resilience, sleep. Secondary to the heart surgery, I had something happen to my brain. And they call it cognitive disruption. And I have persistent things that go along with that. But they're nuisances. And but if you didn't know and I didn't disclose it and explain it to you, you might wonder why I'm acting the way I'm acting. So, and then we, once we understand, because we have sought to understand, then we need to be compassionate, and we need to remember all of our people first ideas, and we need to interface with that individual, not their injury or their disability or their impairment. So this one, this category here has to do with size considerations. And this is another area that can be difficult to communicate about. And so we have people that are short stature. We have people that are very tall. I've worked with a lot of larger, tall people, and they don't fit anywhere. And so if I've worked with somebody that's been on a plane and they don't fit, then they're going to have some tightness and stuff related to trying to hold themselves in a smaller space than what they're used to, okay? So one of the things that we work with that is just that can be disturbing, and there's a level of prejudice about this, is obesity. And there's a lot underlying this. It's more than just overeating. And people have opinions about being overweight. And I've always personally been a little on the chunkier side. And so by the charts, I am obese. And but I function just fine, and all of my blood parameters are just fine. And yes, probably it would be a good thing if I were to moderate the weight a little bit. But I don't want somebody judging me. And so this also can go back to some eating disorders that would have been discussed in the digestive section of your Essential Science book. So our our attempts to control our size, a place can be with your food. And there's a lot of comfort in the neurochemical process of digestion of foods, similar to other forms of comfort care. And food can be a companion. It can be a way of coping. And genetically, there is some traits that are part of this as well. And then you can have your eating disorders where there is purging, which would be taking laxatives and throwing up, vomiting, and it can be isolating your food to just one or two different kinds. It can be limiting food intake. We think of anorexia. Very complicated, very, very complicated. Massage is good. But especially in the eating disorder area, there should be some additional expert help there. And you may be one of the first ones to notice that. So it probably is worthwhile to read up a little bit on eating disorders. Being able to adapt to a person who is larger is important. And to understand the different pressures and the idea of where is the fat distribution and how that might affect positioning. If a lot of the fat is held in the abdomen, then laying on their tummy may not be comfortable. A mat on the floor has worked well for me, but it would not work if somebody had mobility issues in addition to or in combination with the obesity. So this is going to give you some ideas on how to manage that. And you just need to communicate with people and do it from the intention of wanting to understand, not to try to reverse or to judge or to give recommendations or anything else. Help me understand what I need to do to make this environment most conducive for you. And that takes practice to do that. And then we have acquired disfigurement that might happen with burns, or people might have had some sort of a crush injury, or they might be born with a disfigurement. We can, the plastic surgeons and the craniofacial surgeons and so forth, they can do a lot, but there are some things that there's limits to the reversal. It's a natural tendency for us to look. And we just have to know that we're going to do that because we're trying to process the difference. And we need to respond by knowing that we're going to do that and acknowledging that you might be a little uncomfortable and that it is your intention to get over that as quickly as you can. And that person who has the disfigurement is going to know that because they live with it every day. So it takes a little time to get to where you see the person. And so if you're going to work with people, then you need to be able to challenge yourself on these issues. Because the client deserves somebody who will challenge themselves on these issues to get better at it. but it is a learning curve, and it is an experiential curve, and it's part of exposure. So, okay. Diversity and differences is okay. All right. So make sure you read your key points, and let's see what we've got next. So we're going to stop this video here and come back and look at this area. If there is a psychological process going on, these are not physically seen. It's not like a physical disability that is observable. So this takes a little bit of internal reflection as well, and a learning curve. The more you know about something, the less mysterious or frightening it is. And so it's that's you. That's part of your ongoing forever and ever professional development on that, is that you see each unique circumstance that you encounter as a way of improving your ability to appreciate diversity and learn how to adapt your massage skills, adapt your environment in order to support people. So there we go. This whole chapter is about people and how we use our massage skills to help people. Okay. And animals.